It's exciting to welcome Brent Turner here today for the Distinguished Speaker Series, and as also part of the Healthcare Club. And Brent has had a really amazing career in healthcare here in his town, is really, really well known, and you'll see as I read some of his bio, he's had his fingers in a lot of different pieces of the healthcare ecosystem here. So just a deep set of Nashville healthcare provider side of a business. He's currently the Chief Executive Officer and a member of the Board of Directors of Summit Behavioral Health, and we're going to be, of course, talking about that a good bit this evening, but it's a leading inpatient behavioral health care company based just down 65 in Franklin, Tennessee. Summit owns and operates a network of behavioral health and addiction treatment centers throughout the country with 24 freestanding facilities in 17 states. Brent previously served as president of Acadia, and that is one, of course, that he had a long run at, was there from 2011-12 to 2019 in a couple different roles, but eventually president and publicly traded firm on NASDAQ here in town. And he serves on the board of a couple different healthcare concerns, LHC Group, Inc., which is a NASDAQ-traded firm, and Surgery Partners, another NASDAQ-traded firm. He previously served on the board of trustees of the National Association of Behavioral Health, including his time as chairman of that organization. Brent began his career at First Union National Bank, so started as a banker, and we're going to ask you a little bit about how that transition went along the way, and in other corporate finance roles, including CCA, again, another Nashville-based organization, before heading off into healthcare. But of course, around Vanderbilt, he's best known for the fact that he was indeed captain of the football team as an undergraduate student, and reminded me that that stadium that we will hold commencement with is as old as Moses. Is that what you said? You know,
been there a while.
It's been there a while. You played in that stadium, is what you're saying. And graduated with economics in 1988, and later came to Owen as part of a 3-2 program, I assume, at that time.
Yep.
And graduated in '89 from the Owen School. And he's got 2 children and a lovely wife. They live down in Franklin, so great to have you here.
Thanks, Eric. Appreciate that.
Well, you know, I started off by telling a little bit about some of your career in that bio, but I'd love to hear a little bit about how did that work? You left Owen. Did you go to the bank first?
I did. So, you know, you hit on it when you just, you know, I came through the joint baccalaureate program, which Vanderbilt offered, and maybe still does, but 3-2,
Yep.
Technically it was 3.5 undergrad, 1.5 at
Yep.
Owen. And I did that because I was playing football, I got redshirted. I wanted to maximize the opportunity from an education standpoint. So that was the good side of me getting an MBA compressed with the undergraduate. The bad side is I was pretty green. It's St. Patrick's, so it's in vogue, but I didn't really know what, you know, I was interviewing with people and trying to figure out, well, what does that company do? What they're called Goldman Sachs, what do they do? I just didn't have a lot of experience.
Yeah.
And so I knew where I ended up doing was looking at the public accounting firms or corporate banking, just to get some, you know, foundational trading. So ended up going to First Union through their corporate associate program, getting into the relationships management side of banking, and came back to Nashville and worked out of their bank here. Went to Charlotte for a period of time for training, and then relocated or came back to Nashville. And I did banking for about 7 years, and really, you know, got started figuring out. I like to tell people I got my Owen degree in arrears, because I would see companies and how they're doing things and be analyzed in the loan opportunity. Go, oh, that's what they were teaching in Mr. Lindley's strategy class. You know,
Right.
Things start really coming to light. But over the course of those 7 years, I knew I wanted to do something a little different, and I first got into the prison business. Some people think it's because I went to prison, but that's not true. Corrections Corporation, now called
CCA.
Core Civic,
Yep.
was a high growth company. They were a client of mine. And so I went to the CFO. I knew he was working 7 days a week. I said, I think I can help you. And he's like, well, we don't want to lose our banker. And I'm doing something else. So this is the only way you're keeping your banker is by hiring me. And so moved into the corporate finance side of of business and really enjoyed a little more tangible for me ownership in what we do, not just delivering, a service. And so that was a good run through the 90s. And then I'd always thought about healthcare, even when I exited banking. But at least back in the early 90s, healthcare was a little tight community, right?
I was going to ask you
hard
that.
to
How did you
penetrate.
make that pivot? Because Nashville's notorious for being kind of that tight.
And it's not snobbery. It's the fact that those companies, like let's just call the Grand Poobah, HCA, right? A great company. They're training talent every day inside that organization. They don't have to often look outside to hire someone, and so it's really a luck is how I got into healthcare. So I'd been at CCA. I went and thought I want to be the CFO now. Went to a small kind of early stage company and learned exactly the trials and tribulations of being a CFO of a startup type company. It was a little more than a startup. And I got a call from a person I'd networked a lot with around recruiting, and he kind of was very vague, but he said, I got this healthcare company. And so I got excited, and they talked about the opportunity. And then he finally told me who it was after a couple of meetings, and it turned out it was Psychiatric Solutions, Inc. I said, well, that's sort of healthcare, right? We all have a bias, right? And this was almost 20 years ago. And believe it or not, that was just a wonderful, entry point. But they needed someone that had financing and capital markets experience. And I had gotten that through CCA being public with the NASDAQ. And Psychiatric Solutions had just gotten public through a reverse merger in a year prior and needed a financing person to go along with the person they had as the chief accounting officer. So that was the role that brought me, onto that side of the equation as far as getting into healthcare.
And then from there, what was the next jump?
So Psychiatric Solutions, when I joined there, we were 6 facilities and about $100 million in revenue. That was 2003. It was the beginning stages of what I call the kind of the return of inpatient behavioral health. The 90s had been really difficult in this subsector of healthcare due to some changing dynamics in reimbursement and so forth. But the business was coming back. There was a void all of a sudden, and we grew from that 6 facilities to almost 100 facilities by 2010, and stayed public, continued to grow the value of the company. And then in 2010, we actually looked to take the company private, and then the old strategic acquirer showed up, and we got acquired by our largest competitor, and that was in November 2010. And by that time, we were about 100 facilities and almost $2 billion in revenue. And so the team that did that decided, you know what, we're not done. In fact, we were just getting going, figuring it out. And so that's when we joined Acadia in February of 2011. And it was almost we sometimes say, PSI 2.0, another iteration, because it also had 6 facilities and $60 million in revenue when we went over and joined that company and started. It was really a replication of Psych Solutions. The difference was more and more appreciation of mental health was occurring. Mental health parity as a federal legislation had been passed. And so all of a sudden you had a lot of momentum around payers covering not just psychiatric hospitalization, but addiction treatment, right? Back in the 90s, that was all paid out of individual pockets or community dollars, and now all of a sudden people have coverage for behavioral health, and so that was a real new gear for our industry.
That's neat. And then Summit. So is Summit kind of 2.0, 3.0?
It's certainly 3.0 for me, absolutely. So as you mentioned, I was at Acadia until March of 19. Taking some time off and was actually looking at some different things. I've been in behavioral health, inpatient behavioral health for almost 20 years, looking at a few different things. And then I knew of Summit because the founders of Summit both came out of Acadia. They left Acadia and started Summit. And we had watched from afar what they had done. I stayed in touch with them. I'm friends with them. And had some changing in the leadership, and a friend of mine actually became the CEO over there during my time out period, my non-compete period. And so I thought, well, that's an opportunity that probably won't come around in the window I'm ready to get back in. Well, it did. He came to me, I thought for some advice, and it turned out he had a situation that he needed to not be focused on running the business for the next 5 years. and just said, hey, I don't want you to come in. You're the right person. And so, ironically enough, it was a perfect fit. He's shifted over. He's the president of the company, and I'm the CEO. And it's more the same. Summit was primarily substance use disorder treatment, residential treatment centers in the beginning, but in the last 18 months, we've brought on 4 acute psychiatric hospitals and a lot of outpatient levels of care around our facility. So diversifying the care, much like Psych Solutions and certainly Acadia with the addiction treatment services.
And that outpatient piece, of course, is pervasive in healthcare right now. Is that the growth engine of Summit? I mean, is that where you see the change going in your own business model? And
it's interesting because you're so right, and you mentioned my affiliation with LHC Group, which is home health and hospice out of facilities, right, in the home, low cost, efficient, and then Surgery Partners, ambulatory surgery centers and specialty hospitals out of the overnight stays, very lower cost setting. The irony is in behavioral health, both on the inpatient when you have a mental health crisis, as well as when you need residential treatment, I still believe it's not such a push to go to outpatient. When someone comes to a psych hospital, the criteria for admission is harm to self, harm to someone else.
Yeah.
You don't really want that person treated at home, right? You want them to be treated with a lot of oversight and safety for them and anyone around them. And similarly with the substance use, right, there are medically assisted treatment programs, but sometimes people need a time out, right? They need to step back and use cognitive therapy and really reassess and kind of get their feet back on the ground and then move into the outpatient. So at least in our business, I see the outpatient as complementary to what we're doing because we want to step down, get them in the less restrictive area of care as soon as possible. We want to be a part of that because we can also help make sure that they're staying compliant with their treatment plans and everything. So, but I don't see it as we're moving there because the facility's going away. No,
right.
Not at all.
But is it a higher growth segment of the business, do you feel like? Or?
It's getting more publicity these days because it's a sort of a newer one. There's been a couple of PE-backed transactions in the pure outpatient piece of behavioral health, but it's still very, very fragmented. When you just look at clinicians and psychiatrists in a practice, it's a very, very fragmented market. But certainly similar growth dynamics to even the addiction and inpatient levels of care. Yeah.
Yeah. And of course, mental health awareness has never been higher in some sense.
Right.
I mean, I think COVID has probably even accelerated that in a certain way. How has that changed clinical practice? Is it changing clinical practice?
Yeah, I don't know about the clinical practice changing much, Eric, but listen, we all see it. There used to be, you wouldn't really even mention if you knew somebody that had behavioral health, right? It was like it was a shameful thing, right? Well, it's not a shameful thing to have diabetes. It's just the luck of the draw, right? Same with heart disease. Well, behavioral health is the same thing. It is an illness, right? And so the more awareness, the more willing people are to talk about it, the more likely someone's willing to reach out to seek care. I think the clinical practices are they're there, right? And the fact that it's more awareness hasn't really changed how we do the care, but we certainly are more open to how open houses. You're not behind the fence. It's not a mystery anymore. It's a much more transparent delivery of care.
Yeah. Which is good, of course. I'm sure everyone in the industry feels that way to some extent, right?
Yeah, well, as we mentioned, used to be in prison business, and people think Shawshank Redemption, right? Well, that's nothing like really how prisons are run, right? At least, and similarly in psych hospitals, you think of One Flew Over the Cuckoo's Nest or some of those movies. Well, that's Hollywood's version of those businesses, right? Or those institutions. It's much different in the real world.
Yeah. But part of this is again a kind of a 3.0 in the sense that now you're moving into other states, you're expanding. That's something you've had practice doing.
Yes.
I'm curious, looking at the past and then thinking about what you're doing at BHC now. How do you transfer that culture as you're building and expanding out? From what is a fairly small network to something
Absolutely.
that's growing and growing fast.
Yeah.
How do you do that?
Well, again, a lot of our growth historically across the two other companies was more from an acquisition, acquiring existing facilities. And really in healthcare, the healthcare protocols, the milieu, how the care is delivered is really governed by the local physicians in that local market. There's no sort of overlapping, like this is the way we do it. We do have those kind of mindset and policies around appropriate levels of care, but the clinical practice has a lot of diversity depending on where the folk, what part of the country you're in. So we just, we try to make sure as we make acquisitions that we understand the philosophy and how the treatment, has historically been delivered and whether or not that fits within our, approach going forward. And then, at Summit, we're doing a lot of more greenfield or de novo openings where we build a facility or renovate something and then open it up as a new facility. And that's where you can put your people in there. And so it's newer. And so you establish the culture. And I think, again, in behavioral health, it doesn't matter if someone's running an outpatient clinical practice or a 100-bed psych hospital. Your mission has to be to take care of the patients, right? And so Summit, it's our corporate philosophy is improve the lives we touch, right? And you think about it, that covers our employees, covers the patients we care for and their families, and then the referral sources and payers. So that's if we can do that, and that's going to kind of keep us going, and that's kind of what we focus on every day is just improving the lives we touch.
Yeah. You've been talking about this a bit, but when you think about the innovation that's going on in the behavioral health space, what seems the most exciting to you, or what do you see coming down? If we're skating to the puck, if I've got 5 MBA students that are dreaming about the next Summit behavioral health care, what should they be dreaming about?
Well, I'm always behind the puck for some reason. There is a lot of innovation, and the one thing that I look, the way I look at it is there's help for no matter where someone needs care, there's help, right? And so probably the area I see it most is in what's called TMS. T as in Turner, M as in Mary, S as in Sally, transcranial magnetic stimulation. It's a treatment for depression, and they're even using it in addictive disorders. It's really just a magnet and some pulses into the brain delivered over 30 or so sessions, but very, very good progress in terms of how that's working. And it's an outpatient 30, 45-minute session. And it sort of replaces, or it's a substitute for ECT, which is a much more invasive kind of procedure. Invasive meaning you have to go under anesthesia. So it just, that's a whole different approach. And so with TMS, there's a lot more people that can get, can use that service, and benefit from it. The irony is that, from a medicinal standpoint, or what medicines people take, there's not been a lot of change, right? If you look at efficacy, some of the, drugs from 20 plus years ago are still the go-to prescription drugs. The good news of that is they tend to be generic now and low cost. So that, and then, on the addiction treatment, with the explosion of the opioid addiction issues and what we call the crisis that we've been in the last 10 years, you do have some medicines there that are substitute, right? The Suboxone, Vivitrol, and those sorts of things, to substitute, to try to transition the patient from being focused on, yes, it's more manual. It's a prescribed level of an off ramp. That would to switch them over. Yeah.
And that TMS, is that something you do over a 6, 8, 12-month period? Is that?
No, probably shorter than that. Again, I'm not as you can tell by the way I'm talking, I'm not a clinician. Sure. I'm a business person, but have a lot of appreciation. I would say they recommend 30 visits. I would say it's over 60 days, if not less.
Okay.
Yeah.
Oh, wow.
Yeah, several times a week.
Wow.
But in a clinician's office, a psychiatrist can do this with just in their practice.
And it would be used to attack addictions.
It can be used for addictions. Its most prominent use right now is around depression.
Oh, wow.
Yeah. But I think we're going to find, and again, insurance companies cover it. Similarly, like on ECT, it's not this big scary thing. It's a, impulse, but it's also covered by Medicare and insurance companies. So these are very viable procedures. It's just that TMS is such a easier one, if you will, to access and not be, as disruptive to one's life, in terms of just going to the office and being out there in a 45-minute session.
Yeah. And that payer side is such a big part of building a healthcare business, right? I mean, I'm thinking from the business side, that must be a place where you spend a lot of time thinking and strategizing.
Yeah, I mean, it's interesting in healthcare. The providers and the payers are a little bit like UT and Vandy. You may appreciate them, but you're really competitive with them, right? Because at the end of the day, we sort of share the same goal, take care of the patients, but one's trying to provide the care and one's trying to kind of manage the cost, right? And so, but we figure it out because ultimately, you got the patient in the and is important. So, managed care, the payers are very important. And what we're seeing in behavioral health is like a lot of other areas of healthcare is instead of it just being transactional, right? The old fee for service, you're starting to see more development of whether it's step down, more cohesiveness around the arrangements, ultimately probably leading to some value-based reimbursement where you get paid for more than just caring for the patient while in that facility, but hey, how about managing their care for 60 days post-discharge to ensure, because ultimately that's such a game changer if that patient stays compliant with their protocols, because if you get to a month or two, there's more likely you're going to go for a long time versus any kind of fallback. And so I think we're going to see more and more innovation between providers and payers.
Yep. And I got to believe in the behavioral space, the payer side is evolving just like everything else, right?
Absolutely.
What they're willing to pay for, how, like you said, the value-based kind of approaches and so forth is just, it's changing.
Yeah, I mean, we've come a long way. When I first started in the early 2000s, they had just come, we'd just come out of a real downturn in the industry where you had not only back in the 90s in behavioral health, mental health, there was no in-network, there was no negotiated rates. It was just if you showed up, the payer got a call and they paid. People stayed 30 days. Well, flash forward for the last 20 years, average length of stay has been 9 days for an acute psych hospital patient, and that reimbursement went way down because they started negotiating rates like they have with other providers. What's happened is over time, because of the awareness and the importance, those rates have had reasonable escalations since the low point of the early 2000s. So. Yeah. It's probably appropriately balanced. Yeah. We always want a little more, but it's much more reasonable now.
So I understand that you guys are kind of offering some new services for veterans around your tactical recovery program. You want to talk about that?
Sure.
Tell us a little about what
Sure,
that...
and it's really not new services. Honestly, we got that technical recovery distinction from I believe it's from the VA, which is just a nice acknowledgement of the focused care we give our veterans and in the active duty military. If you think about it, just that life, being in the military adds a level of complexity to people's lives. We got to appreciate what they do, but when they get deployed, lots of things are going on at home. So we've learned that there's that's a unique, they're unique in terms of their experience, and so we've tailored across our facilities some programs to help them feel comfortable when they come in for addiction or inpatient. We even have military units in our acute facilities, and so it's the same. There's a lot of similarities in the clinical treatment, but it just has that focus and distinction that it is designed for the active duty or the veteran themselves. And as you probably know, the VA system has allowed more and more of the veterans to seek care in the, not for profit so much, but away from the VA, because there's
essentially outsourcing.
And it's because it's bottlenecked, right? Yeah. And in behavioral health, timing is everything. Much like if you have a heart attack, you don't want to go on a wait list, right? You got to go to the ER. Right. And so that is such a, and so again, when we see that opportunity to have them outsource that care, we want to make sure there's a specific program that's designed and tailored for those veterans.
Yep. And thinking about where Summit is right now, I've been seeing you guys back in the press even just last week. There's a growth mindset here, right? So you're acquiring, right? And you picked up Seabrook and French Creek in the fall, and I think I saw maybe a couple more even just announced a week or two ago, right?
Yeah.
What is your process like for identifying these, like-minded facilities that would be a great addition to your network? How do you think about that process?
Well, I mean, it starts with, we kind of keep a hit list of who we would like to, have an opportunity to acquire. And then the reality is only so many of those are going to come into play. But you sort of know the landscape of who's out there. And then you've got the bankers that are also marketing, get engaged to do deals. And so we try to stay plugged in across PE-backed companies, individually owned operations, as well as the banker sponsored transactions, and just be, you just try to evaluate. But no matter whether it's a sponsored transaction with a banker or just an individual, our historical across all the companies I've been with, we just have a pretty disciplined approach. You get a 30-day or a 60-day agreement that this is the price if these things prove out, and these things are around financial, are the numbers validated through a quality of earnings, but also clinical and quality, the compliance aspects. And during that window of time, we're also thinking, okay, how are they doing it, and how can we enhance it, improve it, grow it, do it a little differently. And so it just gives us almost a little bit of a running start as you continue to move toward documentation and closing the transaction. Well, we really do, even though it's a new business or new location, we got a pretty good view of how it's been doing and where its opportunities and risks are, so we can hit the ground running and come in and really not talk about, you're getting a new payroll system, right? We try to stay away from that stuff. We try to say, here's the good news of Summit being part of your operation now, not the things that, kind of the slow things down.
Yeah. I'm kind of curious, in your experience with this, because you've been doing this a while, what blows up deals? What is the Achilles heel of a deal like that?
In terms of like just not getting are you talking about like a deal not happening?
Right,
or okay,
right,
so
right. You
inevitably
get into that period and it blows up at 60 days. Or 90 days.
Inevitably it's around either a clinical issue, clinical meaning the operation has had some issues and you weren't as aware of it. You get in, you're looking at your legal team's reviewing things, and you see some regulatory activity that we all have oversight, but it might be, this isn't good, right? Or conversely, it's around price. Because again, when you're just talking, it's a private business. You don't know what you only know the numbers they've shared with you. But then when you do the quality of earnings, you're testing it to see, what's really converting here to cash. What's their cash earnings? And so you get to a point where you may have, we have a little latitude around reasonableness, but sometimes it's a big change, and the seller can't, they're like, no, our number, this is my number. Like, well, that's your number, but here's our number.
Accountants say it's something else.
Exactly. And again, it's just it's a discretionary decision on where but most of the time, we end up closing on a lot more than we end up, having fall apart. Because especially these days, even in the last 15 years, the quality of earnings is so understood. It's done by an independent third party in most cases. So, and they, the sellers get it and the buyers get it. In fact, quite frankly, in a lot of the deals these days in healthcare, we saw it first over in the United Kingdom, but the sellers do the quality of earnings, so it's ready, And so that's what's happening here in the U.S. It also speeds the transaction. Instead of having a buyer have to then pause and do a 30-day third-party quality of earnings, it's already done. You might have an update to it, and it's done and attested to by a accounting firm or independent. Exactly. So
Is it, do you feel right now, is it a kind of a buyer's market or seller's market for the?
yes, it's both, and I say it's both because with the COVID pandemic, right? There was, there was a lot of like, what are we going to do? How are we going to do business? But then there was a lot of private equity backed companies that were sort of thinking 19 or 20 is going to be our exit year. Well, we're at 21. And so there's some pent up demand. So I think there's some deals out there. So it makes it somewhat of a buyer's market. But again, the characteristics of the behavioral space are still very attractive. So, you're not getting too many things on the cheap these days. So it's good for the buyers and good for the sellers.
That's interesting. Yeah, but one of the things that I'll do a little infomercial, but you may have seen this, is that there's been, so much interest in deal making in Nashville. It keeps growing and growing. And so we see more and more events in the city around this. And last year there was a new conference called Deal Makers that launched here. I don't know if you came by there. I think I saw some people from your team there. I might have. But we're running it again this spring. And so when I say we, I'm on the group, the host group. But it's just fascinating how many deals are happening in Nashville right now. So you start, opening up a conference space around that. It's post-education, but it's trying to, bring lots of buyers and sellers together. It's not hard to fill a room.
That's right.
This year it'll be a virtual room, but there's a lot happening.
Yeah.
That's great. Well, you mentioned COVID. What's COVID been like for your company? I mean, first of all, how's it affected the addiction and behavioral space, and what have you learned over the last year running your own business through COVID?
Well, initially, I'll say I was getting more COVID education around business and making the adjustments through my board roles because I joined Summit back in the late summer. Right. So I saw LHC Group, a home health company, really having to it was unbelievable, the transition, because the blocking and tackling not only became delivering the care to our patients, but is how do we get PPE, right? How do we get masks and gloves and appropriate to get out to all of our locations? And similarly, and this is unbelievable, but Surgery Partners, the government, right? Governments across the country shut down elective procedures. Right. So here's a company that was told you can't operate. No pun intended. You can't operate, right? So it was unbelievable, the adjustment to handling that kind, and then coming back when you can reopen, having the protocols in place to give comfort to the staff and the patients that hey, we're doing the right things to minimize any chance of transference of COVID, right? So back at Summit and and all of our inpatient, brethren, it was a big mind shift, right? Because when you're in inpatient behavioral health, you're in tight quarters, right? You're going to generally be roomed with someone. So there's 2 people in every room, in each room, and staff. I mean, there's contact, and so we had to establish protocols around masks and social distancing and the treatment and therapy that's going on. And really, it was, what we saw is just the people that do behavioral health at the facility level and the outpatient, they're not doing it for the get right. They're doing it because of the passion. And once again, it was just another notch up on the appreciation you have for them because they did the masks, they came to work, right? There was a time we were like, is it safe to go? They were there, right? I mean, so what we learned a lot, and we went from fear of, is our business going away, to like, wait a minute, we've got it, we can do this. And there's a lot more need out there because when people are in isolation and not being limited on all of a sudden the mental health challenges become even more and more prevalent. Yeah. So our business, and I know many of our peers, has definitely not slowed down from due to COVID. It's probably picked up pace. But even today, we have protocols around, if a patient identifies as positive, how we quarantine them, get them discharged to a safer environment, or take care of them in a separate unit. There's just so many things that 15 months ago you didn't even think about. those kind of.
And I assume a lot of those facilities really got locked down pretty tight. I mean, no visitors, all that kind of stuff.
Oh, absolutely. Yeah. Visitation, with like a lot of places, you want to minimize who's coming and going. But yeah, the visitation has been something that would be has been the slowest thing to come back.
That's great.
Yeah.
So I want to pivot to a couple of more kind of career learnings or leadership lessons and so forth. But I'm also going to be coming to you all for questions you have for our speakers. So if you have
I gave them a couple of easy ones for me before we started.
Good, slipped out the cards. Yeah, but one of the ones that I hear a lot and from our students and of course from a lot of guests is the value of mentorship and how mentorship helps people in their careers.
Yeah.
And I'm kind of curious, in your own career, were there people that you felt played that role for you? How did you identify them? Were they helpful? How do you think about mentorship for your own team?
Yeah, absolutely. I mean, well, we talked about when I got over to healthcare, it was through joining Psychiatric Solutions, and the founding CEO at the time was Joey Jacobs. He was also CEO at Acadia, and very much a mentor to me because I hadn't been in healthcare, so I learned healthcare watching him, lead these companies and leaning in and doing my job and really getting some exposure in other areas. That was the other thing that it was as a mentor he gave me. I went from being just a pure financing person to getting some operational experience because over time I had the initial dream of being that CFO, but then when all the securities and everything with SEC requirements, I thought, I might want to be something a little different than the CFO. That's a hard job. You got to know a lot of facts, and so wanted to be more in the leadership, president, and so got that exposure. But definitely, so he was a real important mentor of mine. And I'm a team sport guy. I play, I tell people these days, because it's been so long that I played football at Vanderbilt. I didn't play a lot, but I was on the team. And so there's something to be said about it. I'm a collaborator. I try to bring people together and, give them a little guidance and then get out of the way, right? And so, I've also learned a lot even being on the board of a couple of I was fortunate, 10 years ago almost to become a board member of public home health. I didn't know anything about home health. I just knew there was reputational issues around, is there some questionable providers? So the first thing I asked was people that I knew, what do you know of this management team? And they're like, they're great. They're in Lafayette, Louisiana, which I had to find out how to get there. But the company's LHC Group, the CEO is Keith Myers, and man, he's been a huge mentor to me to see another subsector of healthcare and how somebody can do it much differently than what I've seen, but yet tremendously successful. He's just an unbelievable servant leader, and it's a company. He was the founding CEO when it had one agency, and now it's $3 billion in revenue. He's still the CEO. It's unbelievable, right? That just doesn't happen much to ride with a company over the beginning until they're great. So those are a couple of the probably mentor examples that come to mind.
Yeah. And it is interesting. You point out that skill set. And do you feel like there's a sweet spot for your skill set in terms of ramping up a company or managing a bigger kind of company that's not ramping anymore?
I definitely think just given my where I cut my teeth, growth, growth through acquisitions and development is really, it's what I enjoy, right? There's a lot to be said about focusing and being more efficient on the small things to make a difference, but my attention is limited, so I'm better about seeing new things and trying to make them come together and grow. So definitely that's and so when I joined Summit, that was a couple of private equity firms. We talked with what's your vision? Do you all still have some capacity to deploy for growth? Because that's kind of what I've been doing, and as you point out, we've made I think 4 acquisitions already since I've been with the company.
Yeah, that's great.
Yeah.
That's great. Well, you've been talking a lot about this already, but is there one leadership lesson you can leave with us from your career?
There's probably a couple. I mean,
give us 2 then.
I would say one. I'm a big believer in leading by example, right? I don't have to do every job that's out there, but I got to absolutely appreciate the hard work and what it is that gets done by the team. But also really important about don't be worried about making a mistake, right? I didn't make hundreds here at Owen, and I don't make hundreds at my job, but you gotta put a mark on the page to get a grade. And so it's all about, not worrying about being perfect and not making mistakes, but being willing to make mistakes. What I've learned is you can be paralyzed by indecision versus making a decision and then pivoting and already being in a different place while you might have been still trying to ponder it. So
Right.
it's all about, being confident about making a decision, have thought about it, but then if it doesn't work, try the other path. Usually that door will open.
That's great.
Yeah.
That's great. Well, questions from the studio or online audience? Awesome. Got a couple.
I'm Renee Casali, second year MBA. I guess it's on the same topic. Just wondering, a lot of us have been individual contributors for most of our careers at this point, and so we're transitioning to more managerial roles. So what's your one advice that you wish you'd known early in your career in terms of leading teams and kind of stepping away from those like individual tasks and more of like a broader perspective?
Boy, that is a great question. And should I repeat it? Yeah. I'll try to paraphrase the question. It was, how do you transition from being an individual role player in an organization to a managerial role? And honestly, I think it's just I don't think you ever distance completely from those individual contributors. Again, sort of like I said before, being a active leader, right? You take those, but then you're able to deploy your knowledge across a broader group. And so what I've found is it's really about a willingness. Look for those opportunities because sometimes they're more obvious than we think, and you're building on the foundations of what you do to be in that managerial position. Some people want to be down in the accounting department, happy to be there. For me, I didn't know enough about accounting, so I had to try to find that managerial leadership, need to deploy some of my, gift for gab, if you will. So,
That's great. That's great. I saw another hand back there. Yeah.
Hey, Brent, it's Teddy.
Teddy, I didn't recognize you behind the mask, but that's.
I'll ask these easy questions for you then, I guess.
So, by the way, y'all can ask him, and you'll find out if I didn't tell anything that was exactly accurate, because Teddy used to work for us. Yeah.
Worked for Acadia for 3 years, but talked a lot about how Summit is kind of 3.0 for you. Can you talk about some of the things that you learned at PSI and Acadia that you plan to do differently, and some of the things that you plan to do the same, whether that be kind of culturally or with the business, just some of the things that you've learned in doing differently and doing the same?
Yeah, I mean, yeah, and he asked, the question was around, as I've joined Summit, what are some of the approaches that'll be different or similar to the two predecessor companies? And to state the obvious, the biggest difference is I'm the CEO of Summit, right? So before I was always in a supporting role, right? And it's great. You can get a Best Supporting Actor role, award for that. But in my phase of career, I wanted to see if I could, be the CEO. And to me, all that, once again, it's just ultimately I've got the ultimate responsibility to help the team perform. And so look at a lot of the same aspects. Again, try to stay focused on, the patients, improving the lives that we care for. But we're definitely going to, just like we're all individuals, I'm going to do things differently. I'm going to try to leverage the things I've learned from, but we learn do's and don'ts. And so, I don't have a real list, but what I know is I bring to Summit every day Brent Turner. That's who I am. I'm not trying to be somebody else. Just come bring my leadership and my view, and hopefully, we'll come together. And I know, we've got a great team at Summit, and we're really collaborative, talk about things, figure out, is this the right market? Why should we be there? Why should we not be there? And that sort of thing. So I think just what's mentioned earlier, just a very collaborative approach.
That's great. Other questions?
We have one online question from Rachel Johnson. She asks, some studies show that behavioral patients often spend significantly more time than non-psychiatric patients in ERs and hospitals due to the lack of specialists or resources. How do Summit facilities partner with other hospitals in their markets to support the patient population that needs more dedicated care? It's
a great question. Great question. It's so true. If you if you think about presenting to, and do I need to I'm sorry, I
A
thought.
little bit of it, yeah. So Rachel
Yeah.
Johnson asked.
I thought he was online. Yeah,
Rachel asked a great question.
Yeah, great question. Obviously, she knows a lot about behavioral health. The question, again, paraphrase, was how can we help as an inpatient provider support, I'll call it the pathway of the patient when they need care, because certainly on acute psychiatric issues, and that's where if someone has a mental health crisis, the first thing people do is they either call the police, families call, or they rush the patient to the ER. And the ER right here is Vanderbilt University Medical Center. Well, that's not the last place they need to go, but they've got heart attacks, car wrecks. Right. So here you have a behavioral patient present. Now, Vanderbilt's got the benefit of having Vandy Psychiatric Hospital right down the road. So they're going to triage that patient as quickly as they can, because that's where this type of care is delivered. So at Summit and at the predecessor companies, we always make sure that those facilities that we know are going to be more likely to have that psychiatric presentment know exactly how to get us. And it's not an inconvenience. 2 p.m., 2 a.m., Saturday, Tuesday, that's just what we do. That's what the facility does. And so it doesn't solve the problem, because there's always, the ER can be a bottleneck with mental health patients. But certainly more care providers from an inpatient behavioral health standpoint helps those hospitals sort of offload, get the patient to care quicker. Now, what's happening in a lot of markets is that med-surg hospitals who don't have any provision of mental health are starting to, the last 8 years, starting to figure out, wait a minute, why don't we partner with a psychiatric provider versus just sending them our patients as a courtesy? So you're seeing more and more joint ventures where the med-surg hospital is joint venturing with the psychiatric.
And they get some revenue benefit.
And they're sharing, absolutely. There's a partnership, and so you share in the proportionally with the cash flows, and yet the same type of patient flow is happening, because that's what needs to happen. Yeah. So that's probably a big change there as far as enhancing some markets' care delivery there for these patients.
That's great. Thank you, Rachel. Another question? Yeah.
Good evening, sir. Zach Nelson, first year MBA. How would you say that through the pandemic, or even in your past work at Acadia, how would you say that you connected with your employees, and especially leading through dynamic change such as COVID? How did you ensure that your message and your vision of touching people's lives or changing people's lives that you touch, how did you ensure that got down all the way to the people, whether it was virtually, remotely, or at other facilities throughout the nation?
Yeah.
I'll try to repeat it for you. So Zach Nelson, first year MBA, asked a question. He said, during COVID, how do you as a leader be able to connect with the folks out in all the different parts of the organization, and be able to really make sure that they're hearing your message, which of course is really important in a time of craziness, right? I mean,
It's a great question, and what we've seen at Summit, as I mentioned, there was a huge commitment of the employees to take care of the patients in this very challenging environment. So what we try to do is just make sure the employee gave them all the information and resources to know that we were watching trends and trying to be an employee-friendly, company. And really where I saw it, and what we did on a more case, is anywhere where we had a little bit of a hot spot with the go, is reaching out, figuring out what can we do for these employees for appreciation, right? Do we give them a little, bone, just some kind of message to say, look, thank you.
It's hard.
Yeah, it's hard.
You're doing it.
And this doesn't make it perfect, but and so. And a lot of testing, a lot of making sure that testing was available for our staff when there was a hot spot. They didn't have to go to a clinic, just come in and they could be tested at the facility, those sort of things. I think it's just a testament to the caregivers, in the med-surg hospitals, but also in our behavioral facilities.
And how would they hear from you during that time? I mean, were you on Zoom? Were you,
It was really, honestly, we got those 24 facilities. They have leadership teams in each location, and they're very autonomous, right? The parent company supports, and our messaging goes through leadership there. So I don't get on a Zoom with the whole company. The company's busy taking care of patients, right? But we make sure if they have a need, don't fret over it. Just tell us what you need and we'll get it for you. So it's constant communication with their leadership team about giving them access and latitude to do things, that can be, and ultimately Summit is the employer, but it's really happening at that local.
So supporting the local
yeah,
leadership to
exactly.
help them be effective.
Exactly.
That's great. Maybe one more. Yes.
Hi, I'm Nora Sultan, so I'm interested in finding out more information about what opportunities are at Summit because the Vanderbilt Healthcare Club and the Career Management Center would like to strengthen Nashville opportunities. So if you could tell us a little bit more.
Sure.
And Nora leads our healthcare club, and she wants to know what kind of opportunities that there are in the business.
For students and I think it's a great question, and I can say certainly at Acadia we hired a number of Owen interns that then became in our leadership program, CEO in training, and Summit's much smaller, but we're starting to do the same kind of programming. So I will be happy to give you my contact info and make sure people know where Summit is, because as we grow, we're going to look for great talent, and it's Owen is obviously in the past, but certainly even more so nowadays, generating a lot of good talent, and people want to be in healthcare, and certainly behavioral healthcare. We want them to think of Summit, so it would be great.
Do we have one more online? Rowdy Sand, was it?
Yes, Jack Ballant asks, a big part of behavioral health is engaging the patient's family to ensure positive clinical outcomes. How does Summit interact with patients' support systems?
So Jack, it was Jack, right?
Yes.
Jack was asking, how does Summit interact with behavioral health systems? Did I get that?
With the patient's families.
Patient family,
Yeah,
excuse me.
yeah.
Sorry. Very good.
There's probably it's great. Yeah, people have been doing some homework around this. That's another great question. Honestly, that's a great question. It's so insightful.
you, Jack.
It's so insightful because, if you think about it, physical health or behavioral health, it takes a village, right? I mean, and so the family is such a key part of, recovery or, mental health, dealing with a mental health illness. It's a balancing act, though, right? You got HIPAA law. There's governing issues that control that. But anytime we can bring the family into the equation, it's usually additive to the positive recovery of the patient. When they're in our facilities, it's really, the families get more involved as they step down into the outpatient treatment. But it's absolutely critical. I'll just say, if you think about medically assisted treatment for the opioid addiction, there was a time where people just thought, if they can just get the medicine to offset the craving, that's the solution. Well, there's been all kinds of studies that say that's actually not even close, because that's just a piece of the issue. The medicine, the substitute, the clinical counseling is hugely important. But then that support structure, i.e. the family, is the real glue that brings it all together. So again, I say Jack has a real insightful question. I don't know that Summit has all the answers for how that's done, but it's absolutely on our front and foremost.
That's great. Well, Brent, obviously healthcare is of huge interest to the Owen School. I would say 20% or so of our students end up in healthcare. A lot of them right here in this town. I'm sure you interact with a lot of alums over your time in the business, and so it's just a real delight to have you here as a leader in that space and learning from you. So thanks so much for joining us.
I appreciate it. It's been very enjoyable. Thanks for having me.
Great. Thank you, everybody.